My talk is going to be about the link between endothelial dysfunction and systemic hypertension. This has been quite a contentious area over the years, and in particular it's been very unclear for many years whether hypertension per se is indeed associated with endothelial dysfunction. And it's only in more recent years that the situation has really clarified itself. In this talk, I'm going to start off saying a few words about the endothelium, what it is, its structure and its function. I will then focus down on one of the most important mediators that is produced by the endothelium, namely nitric oxide, and its role in hypertension. I will then go on to talk about the clinical and prognostic importance of endothelial dysfunction in hypertension. And finally, I will say a few words about therapeutic implications, and in particular, whether ameliorating endothelial dysfunction may be of therapeutic value in the treatment of patients with raised blood pressure. So to start off, the endothelium lines the inner surface of all blood vessels in the body. It is a single layer of cells and it produces a variety of mediators, one of the most important being nitric oxide. And nitric oxide production by the endothelium can be triggered by a variety of pharmacological agents, but physiologically, one of the most important stimuli for NO release by the endothelium is shear stress and increased pressure. Nitric oxide causes vasodilatation, and it's one of a number of mediators produced by the endothelium that is said to be protective in that it causes vasodilatation, causes growth inhibition, is antithrombotic, anti-inflammatory, and antioxidant. There are other mediators that are also produced by the endothelium, which I'll come on to in a little while, which do much the same thing. And on the other hand, there are other endothelium-derived mediators which are considered to be deleterious in as far as they cause vasoconstriction, growth promotion, they're prothrombotic, pro-inflammatory, and pro-oxidant. And in the normal healthy individual, there is a balance between the so-called deleterious factors and the protective factors, the balance being in favour of the protective factors. But in the context of cardiovascular disease, this balance gets shifted. And there is a clear link between endothelial dysfunction and the progression of atherosclerosis. As we know, atherosclerosis, the process of atherogenesis, starts off in childhood with the formation of foam cells, lipid-laden macrophages, which progress to fatty streaks. And later on, in later adult life, you get discrete atheromatous plaque formation. And then in complicated cases, the plaque can rupture with superadded thrombosis. And that's where platelets can play an important role in causing the acute thrombotic event on a ruptured or fissured plaque. And it is clear now that there is a clear link between degree of endothelial dysfunction and progression of atherosclerosis. And it has been unclear whether that link is causal, in other words, whether endothelial dysfunction gives rise to progression of atherosclerosis. And there is now increasing evidence that indeed there is a causal role for endothelial dysfunction in the progression of this disease. Now, as I mentioned, one of the most important endothelial-derived mediators is nitric oxide, but there are others, as shown on this slide. Prostaglandin I2, otherwise known as prostacyclin, and EDHF, which stands for endothelium-derived hyperpolarizing factor. And in fact, EDHF is probably not one factor. It is probably a combination of several factors, including potassium itself, C-type natriuretic peptide, myoendothelial gap junctions, and others as well, which are as yet unrecognized. And all of those exert the protective effects that I alluded to earlier on, in other words, vasodilatation, antithrombosis, etc. And then on the other hand, there are the so-called endothelium-derived constricting factors, or EDCFs, which include endothelin, superoxide anion and other reactive oxygen species, thromboxane A2, prostaglandin endoperoxides, and indeed other EDCFs. And it's the balance between those two that determines whether endothelial function is normal or whether it is abnormal. Focusing down on nitric oxide, this is generated by the conversion of the amino acid L-arginine to L-citrulline by the action of the enzyme nitric oxide synthase. Nitric oxide will then diffuse from the generator cell, in this case the endothelium, to the target cell, which may be the vascular smooth muscle cell or the platelet or other cells, and Most of the actions of nitric oxide appear to be mediated through the activation of the soluble form of guanylyl cyclase, or SGC, which catalyses the formation of cyclic GMP in the target cell. And as I mentioned earlier, one of the most important physiological mediators of nitric oxide release from the endothelium is shear stress, but of course there are other pharmacological agents which are used in research for research purposes, but which are thought to be of lesser importance in normal physiology and indeed in pathophysiology. So the biological effects of nitric oxide are numerous and not just confined to the cardiovascular system. Indeed, in the central nervous system, nitric oxide acts as an important neurotransmitter, and in leukocytes, nitric oxide can be generated, and it has an important role in host defense. But in terms of cardiovascular physiology, one of its important actions is that it causes relaxation of vascular smooth muscle and indeed other smooth muscle. NO also inhibits platelet activation, adhesion and aggregation, and indeed it appears to have an important anti-atherogenic role, and that has been shown in a variety of animal models. And this is through a variety of pathways. Firstly, it inhibits the expression of cellular adhesion molecules such as ICAM and VCAM. It inhibits platelet adhesion and activation, it inhibits smooth muscle proliferation, and it inhibits oxidant stress. Nitric oxide function in the endothelium can be examined through a variety of techniques. One of the most common ones that has been used over the past 2 decades or more is the technique of measuring forearm blood flow through venous occlusion plethysmography. This technique involves examining the function of the endothelium in the forearm microcirculation, in the forearm resistance vessels, in fact. This involves measuring the rate at which the forearm swells in response to vasoactive agents once a blood pressure cuff is applied to the upper arm and periodically inflated to above venous pressure to occlude venous return. And of course what happens then is that the forearm swells. The rate at which the forearm swells depends on forearm blood flow, which can be measured through a strain gauge plethysmograph. And as shown on this slide, you can infuse vasoactive agents such as acetylcholine, or ACH, which is an endothelium-dependent vasodilator, or nitroprusside, or NP, which is an endothelium-independent vasodilator, which works through the release of nitric oxide directly, independent of the endothelium. And by using agents such as these, you can examine endothelium-dependent versus endothelium-independent vasorelaxation in the forearm resistance vessels. And using this technique, you can show that, for example, as you get older, there is a clear decline in endothelial function. So if you compare acetylcholine forearm blood flow in young versus elderly patients, there is a clear impairment in elderly compared with younger patients. By contrast, if you look at the same responses to sodium nitroprusside, there is no difference between the younger and the older cohorts. So we know that endothelial function declines as you get older. Is that simply due to accumulation of cardiovascular risk factors? Because we know that cardiovascular risk factors in themselves can impair endothelial function. So hypertension, dyslipidemia, coronary disease, heart failure, all of these things become more common as you get older. So it may be partly that you accumulate cardiovascular risk factors as you get older, but if you control for all of those, there still seems to be an independent association between age and vascular endothelial function. And it's not all bad news, because there are measures that you can do to improve your endothelial function. So, for example, subjects who undertake regular aerobic exercise have relatively preserved endothelial function. So what about endothelial function and hypertension? Well, this is a study that looked at a cohort of healthy postmenopausal women, and these authors measured their endothelial function using the technique, or FMD, which stands for flow-mediated dilatation. And I'll talk more about FMD in the later part of this talk. But this is a technique for looking at larger vessel endothelial function rather than the resistance microvasculature. And as shown on this slide, there is a clear relationship between the degree of flow-mediated dilatation and relative risk of developing hypertension over a follow-up of 3.6 years on average. So the worse your flow-mediated dilatation, the more at risk you are of developing hypertension in the next 3 to 4 years. And in this particular study, the risk in the lowest quartile of FMD was something like 5.8-fold higher than those in the highest quartile of FMD. A variety of animal models of hypertension have been developed over the years and have been studied in relation to endothelial function. One such model is the dull salt-sensitive rat. This rat is normotensive in the absence of salt, but when it is fed salt, it develops quite severe hypertension. And as shown on this slide, these authors looked at the response of isolated thoracic aorta to acetylcholine, an endothelium-dependent vasodilator, and showed that in the absence of salt, the aorta shows a good concentration-dependent relaxation to acetylcholine, which is largely inhibited in rats which are fed salt, which develop hypertension. They also looked at the activity of nitric oxide synthase in the aortic wall as determined by the conversion of L-arginine to L-citrulline, and showed that in control non-salt fed rats, nitric oxide synthase activity was significantly higher than in the thoracic aortic wall of rats which had been fed salt and become hypertensive, thereby showing that there is clear evidence, in this model at least, of endothelial dysfunction and indeed impaired nitric oxide synthase activity when hypertension develops. And very similar findings have been reported in a whole host of other studies looking at different animal models of hypertension, including the spontaneously hypertensive rat and the 2-kidney 1-clip model, and various others as well. In humans, this has also been extensively studied, and traditionally this was done using the technique that I mentioned of measuring forearm blood flow. And acetylcholine and other muscarinic agonists have been widely used for this purpose, and as shown on this slide, acetylcholine shows a dose-dependent increase in forearm blood flow, and this is greater in normotensives than in hypertensives. And on the bottom of this slide, this is showing forearm vascular resistance, which is essentially showing the mirror image of forearm blood flow. And again, this is showing that in hypertensive subjects, the decrease in forearm vascular resistance in response to acetylcholine is significantly blunted compared with normotensive subjects. But as can be seen, the magnitude of these differences is actually quite small compared to the magnitude of differences that have been seen in the animal models that I mentioned. And indeed, a study done by Cockcroft and colleagues and published in the mid-1990s looked at this in more detail, and they took a cohort of normotensives and another cohort of hypertensives that were very well matched in terms of age, lipid profile, smoking status, and other risk factors. And indeed, they showed that when you control for all those other risk factors, in fact, they couldn't detect a difference in the forearm blood flow response to acetylcholine between the normotensives and the hypertensives. They looked at another muscarinic agonist, carbachol, found exactly the same thing. Isoproterenol is another vasodilator which acts in large part through endothelial release of nitric oxide, and again they found no difference between normotensives and hypertensives. They did a further study which then looked at the effect of other risk factors, and in fact they found that in hypertensive subjects there was an inverse association between levels of cholesterol, total cholesterol in the blood, and forearm blood flow. This association with cholesterol was relatively absent in normotensive controls. So this suggests that in fact hypertension per se may not be an important determinant of endothelial function as assessed at the forearm resistance vessel level, but it may in fact synergize with other cardiovascular risk factors, and in particular cholesterol, to then generate endothelial dysfunction in this vascular bed. What we do know, though, is that the degree of impairment of forearm vasodilatation in response to ACH is correlated quite closely to subsequent cardiovascular events. So if you look at different tertiles of acetylcholine-induced forearm vasodilatation, then those with the highest quartile of ACH vasodilatation show the lowest rate of cardiovascular events at follow-up, and conversely, those with the lowest quartile show the highest number of events. So, is endothelial function indeed compromised in hypertension, or is it not? Well, in the forearm microcirculation, the evidence has been equivocal, and the balance of the evidence seems to suggest that hypertension alone may be insufficient, but it may indeed synergize with other risk factors, and in particular cholesterol, in impairing endothelial function. So that's in forearm resistance vessels. But what about larger vessels? Well, this brings me on to say a few more words about the technique of flow-mediated dilatation, or FMD, otherwise known as reactive hyperemia, and this is another widely used method that has been taken on in the last few years for assessing large artery endothelial function. In brief, this technique involves putting a blood pressure cuff around the forearm and an ultrasonic transducer at the level of the brachial artery. The blood pressure cuff is inflated to suprasystolic pressure for a period of several minutes and then released. And in response to the sudden increase in forearm blood flow, you get a vasodilatation which can be detected in the brachial artery by ultrasound. It has been shown in a number of studies now that this so-called reactive hyperemia is very largely dependent on nitric oxide production. And indeed, if you inhibit nitric oxide production in the individual, then you largely abolish FMD. So reactive hyperemia is a very good way of looking at large artery endothelial functions, in particular nitric oxide related function. And it has been shown that there is a good correlation between the degree of change in brachial artery diameter with reactive hyperemia and coronary endothelial function. This is just one such study, just showing a very close correlation between the degree of reactive hyperemia and the degree of coronary vasodilatation in response to infusion of ATP. And a number of studies, this is just one such study, but a number of studies have now shown that flow-mediated dilatation in the forearm is significantly impaired in subjects with hypertension. A less consistent finding is what happens in response to the the endothelium-independent vasodilator nitroglycerin, or glycerol trinitrate, GTN. This particular study found a slight impairment in GTN-induced vasodilatation in the brachial artery in parallel with the impairment in flow-mediated dilatation in patients with hypertension. But what is clear in this and in other studies is that the impairment of FMD is rather larger than the impairment in GTN-induced vasodilatation. This phenomenon of endothelial production of nitric oxide in larger arteries has an important bearing on arterial stiffness, which in turn has an important consequence in terms of determining blood pressure and in particular pulse pressure. As we've said, the endothelium produces NO, and it has been found that nitric oxide has important effects on arterial compliance or arterial stiffness, both in the short term and in the long term. Immediately it has effects through its vasodilatory effects, but in the longer term, NO has been shown to have structural effects on the blood vessel wall in terms of reducing collagen content, increasing elastin content, and reducing the degree of cross-linking of collagen. And this has an important bearing, as I said, on blood pressure. This is a graph showing how blood pressure changes with age, and on the top, in both men and women, this shows that as you get older, your systolic pressure goes up inexorably. The same is not true, however, of diastolic pressure, as shown on the bottom. In both men and women, diastolic pressure increases with age, but only up to a certain age. And around the late 50s or early 60s, diastolic pressure plateaus, and subsequent to that, it starts to decrease. So in other words, in older subjects, as these subjects get older, the pulse pressure, the difference between systolic and diastolic pressure, tends to go up. Now, pulse pressure is determined by two things. Firstly, the stiffness or compliance, if you like, of large arteries, and secondly, by cardiac output. Now we know that cardiac output doesn't generally increase as you get older, but arterial stiffness does increase. Now this phenomenon was recognised almost 100 years ago by Bramwell and Hill in their seminal paper, and they said at the time that the difference between systolic and diastolic pressure, that is the pulse pressure, other things being equal, will vary directly as the rigidity of the arterial walls. So it has been recognised for a long time, but it's only in recent times that this has been the subject of intensive research. Now, this is a schematic representation of how the arterial waveform is generated. When the heart contracts, there is an outgoing wave which propagates down the large arteries, the aorta and its branches. And at points of bifurcation, that outgoing wave gets reflected back. And so you get a summation of reflected waves which comes back and collides with the outgoing wave to form the characteristic pulse wave that we all know, which has two humps on it. In stiffer arteries, the rate at which the pulse wave propagates will be increased. It will go faster down the arteries. And so it will be reflected back faster, and so the reflected wave will impinge on the outgoing wave at an earlier point, giving rise to an earlier augmentation, so that instead of the characteristic pulse wave that we know, we get a different shaped wave with an increase in systolic pressure and a decrease in diastolic pressure. Now, arterial stiffness can be measured in a variety of ways. These are two common methods that are used. One is to measure pulse wave velocity, because as I said a minute ago, pulse wave velocity, the speed at which the pulse wave propagates, is increased in stiffer vessels. So pulse wave velocity is a very good reflection of arterial stiffness. And this can be measured by looking at the pulse wave at the level of the carotid artery and at the level of the femoral artery. And you can measure the time difference in the foot of those two waves. If you measure the distance over the body over which that time difference occurs, then it's a simple calculation to calculate the pulse wave velocity, which is the distance divided by the time taken for the pulse wave to travel. The second common method that's used is to analyse the pulse wave itself. So, for example, there is a machine called the sphygmocore, which is widely used, which measures the pulse wave at the wrist using a non-invasive pressure sensor, an applanation tonometer, and then by putting it through an algorithm in the machine and putting in the peripheral blood pressure reading, you can get a measure of central blood pressure. And what these techniques reveal is that systolic pressure increases with stiffness and diastolic pressure falls with stiffness. Because the aorta is stiffer, you get less elastic recoil in diastole and a more rapid fall in diastolic blood pressure. And so, as I mentioned before, the major determinant of pulse pressure is in fact arterial stiffness. And this has important hemodynamic consequences because the increase in systolic pressure will give rise to an increased load on the left ventricle. And the decrease in diastolic pressure will give rise to important consequences in terms of coronary artery perfusion because, of course, the coronary arteries are perfused during diastole, not during systole. So reduction in diastolic pressure will give rise to a reduction in coronary perfusion, and this will be especially marked in patients with coronary artery disease. So you might expect an increase in arterial stiffness and thereby an increase in pulse pressure to correlate with an increase in cardiovascular events. And indeed, the evidence suggests that this is indeed the case. These are data from the Framingham study, which were published just over 10 years ago now by Stan Franklin. This shows that, as might be expected, at a given level of diastolic blood pressure, as you increase the systolic pressure, the coronary heart disease hazard ratio goes up, and there's nothing surprising in that. What might be more surprising is that if you look at subjects at a given level of systolic blood pressure, but different levels of diastolic pressure. As the diastolic pressure falls, the coronary hazard ratio goes up again. So at a given level of systolic pressure, diastolic pressure is inversely related to coronary events. And these authors concluded, therefore, that at all levels of systolic blood pressure, diastolic blood pressure was inversely related to coronary heart disease risk, and consequently, pulse pressure emerged as the best predictor of coronary heart disease risk in these older subjects. And they concluded that greater reliance should be given to pulse pressure when assessing cardiovascular risk. So, to recap, pulse pressure is related to cardiovascular risk, and pulse pressure in turn is related to endothelial nitric oxide production, because nitric oxide is an important determinant of arterial stiffness. And as shown here, there is an inverse relationship between the degree of flow-mediated dilatation in the forearm and central blood pressure, which shows this close relationship. And as shown here, there is a hemodynamic consequence to increased arterial stiffness. So in patients with hypertension, as diastolic function is progressively impaired, so is arterial compliance, and it is likely that arterial stiffness in itself is the thing that gives rise to diastolic dysfunction. So in hypertensive patients with normal function, or HTNF, as shown in this graph, there is indeed a reduction in arterial compliance. This is exacerbated in hypertensive patients with impaired diastolic relaxation, or HTIR, and this is further impaired in hypertensive patients who exhibit pseudonormalization, or HTPN. Now, blood pressure, by contrast with the situation of the forearm resistance vessels, does seem to be very closely related to degree of FMD. And this is a meta-analysis that was published recently, looking at the relationship between a whole variety of cardiovascular risk factors and arterial stiffness as measured by pulse wave velocity. And essentially, this meta-analysis showed that age and blood pressure were the two most important determinants of flow-mediated dilatation. Other cardiovascular risk factors did have an effect, including diabetes, cholesterol, sex, smoking, but these were largely outweighed by the effects of age and blood pressure. So, to recap, hypertension is associated with endothelial dysfunction. This is particularly marked in the larger as compared with the smaller vessels. Other cardiovascular risk factors are also associated with endothelial dysfunction, and we believe that one of the main determinants of this, one of the central components that links cardiovascular risk factors to endothelial dysfunction is oxidative stress with the production of reactive oxygen species. This endothelial dysfunction manifests itself in a variety of ways: in impairment of nitric oxide production, increased production of angiotensin II, endothelin, and other vasoconstrictive mediators. There's an increase in production of cellular adhesion molecules such as ICAM and VCAM, giving rise to an increase in inflammation. There is an increase in thrombosis, which is largely determined by an increase in expression of PAI1, which stands for plasminogen activator inhibitor 1. And there is an increased tendency to plaque rupture, which is multifactorial in origin. So, endothelial dysfunction does occur in hypertension. An enduring debate is whether this is cause or consequence. Which is chicken and which is egg? Is it that endothelial dysfunction causes hypertension, or does hypertension cause endothelial dysfunction? Well, there are bits of evidence on either side. In terms of causation, evidence suggesting that endothelial dysfunction may cause hypertension, we know that if we look at the normotensive offspring of hypertensive patients, then those subjects exhibit endothelial dysfunction, even with normal blood pressures at the time. So this suggests that endothelial dysfunction may be genetically determined and indeed may predate the development of hypertension. The evidence that endothelial dysfunction may be a consequence of hypertension rests largely around the evidence that endothelial dysfunction can be largely reversed by antihypertensive treatment, in particular treatment with ACE inhibitors, angiotensin receptor blockers, and calcium channel blockers. So it does seem that treating the hypertension per se may be effective in treating the endothelial dysfunction, suggesting that it may be a consequence rather than a cause. Also, of course, patients with other cardiovascular risk factors, or indeed with established cardiovascular disease, also exhibit endothelial dysfunction, but may do so without the presence of hypertension. So clearly, hypertension is not an invariable consequence of having endothelial dysfunction. So that debate continues. But what we do know is that endothelial dysfunction is a very good predictor of future cardiovascular events. I showed some evidence for this earlier, and this is a more comprehensive analysis of a whole variety of studies that have looked at this, and almost invariably these studies have shown that endothelial dysfunction, however you measure it, whether you measure it by forearm blood flow, whether you measure it by flow-mediated dilatation or through other techniques, endothelial dysfunction is predictive of future cardiovascular events. So there are various strategies that we can use for improving nitric oxide availability and endothelial function. Antihypertensive therapy is one such strategy, as is cholesterol lowering. And we know that both of those, for example, are associated with improved outcomes. But it's entirely unclear whether this is purely due to blood pressure lowering and lipid lowering, or whether it is due, in part at least, to effects on the endothelium. So what we need to do is to intervene with other therapies that improve endothelial function to see if those have an effect on outcome. So, for example, here is an animal model of hypertension, the fructose-fed rat, and such a rat develops hypertension and a whole host of other abnormalities which are part of the metabolic syndrome, very similar to the metabolic syndrome that occurs in humans. So in this graph, as can be seen, control rats remain normotensive. Rats that are fed fructose, labelled as F here, over the course of their life develop sustained hypertension. And this can be ameliorated if these rats are treated with exercise, so they exercise regularly. That reduces the rate at which their systolic blood pressure goes up, and that's labelled as FE here. Rats which are fed taurine, which is in large part an antioxidant, which again improves endothelial function, and that's labelled as FT here. So those rats fed fructose and taurine, again, have a less rapid rise in their systolic pressure with time. And those rats which receive both exercise and taurine in combination with fructose feeding, their blood pressure is very close to that of the control rats. So these are strategies which have been shown to improve endothelial function, and they do indeed appear to lessen the rate at which blood pressure rises in these rats. Well, what about humans? Well, I guess the best known study in terms of measures to improve endothelial function would be the dietary measures as applied in the DASH study. And this is now quite an old study, published in the late 1990s, but essentially these were patients with blood pressures systolic less than 160 and diastolics between 80 and 95, and they were randomized either to receive a control diet, which was a standard American diet, low in fruit and vegetables, high in saturated fats, or they received a diet that was high in fruit and vegetables, or they received a so-called combination diet, which was again high in fruit and vegetables, but also high in non-fat dairy products and low in total fat and saturated fat. And as you see, the combination diet and the fruit and vegetable diet both very effectively reduced both systolic pressure and diastolic pressure in these patients. And this is a study that was done in young women in their late teens, early 20s. This was these data were taken from a study called the Growth and Health Study, where these subjects were followed up for 10 years looking at a whole variety of health outcomes. One of the outcomes that was looked at was blood pressure, and this shows that there is a very good inverse correlation between plasma ascorbic acid levels and both systolic and diastolic pressure, showing that the higher your intake of ascorbic acid, the lower blood pressure seems to be, at least in these young women. Of course, this is an observational study, not an interventional study, and as yet we don't have the intervention studies, at least in young, otherwise healthy people, to see if such measures can prevent future development of hypertension and future development of cardiovascular diseases. We do have, of course, the antioxidant and vitamin trials that have been done in older patients and in those with much more advanced disease and significant risk factors, and those have largely been negative so far, but it is arguable that in those subjects it is too late to intervene at the level of the endothelium. A much more promising strategy, in my view, would be to intervene at a much earlier age in people who are clinically healthy, and the emerging evidence seems to be that it may be much more effective to intervene with measures which improve endothelial function at that early stage, but of course we need more data to prove that for sure. So in summary, hypertension is associated with impaired endothelial function, probably more so in large than in small arteries, and the effect on endothelial function is increased by the presence of concomitant cardiovascular risk factors. In large arteries, endothelial dysfunction gives rise to an increase in arterial stiffness, and that in turn gives rise to an increase in central pulse pressure, and we know that central pulse pressure is directly related to cardiovascular outcomes. The higher your central pulse pressure is, the worse your cardiovascular outcome. And so measures to improve endothelial dysfunction may reduce pulse pressure, and in particular pulse pressure, and especially so if such measures are instigated in early life and in patients at an early stage of disease. Whether that is really the case remains to be proven, and that may in the future translate to improved outcomes. Thank you.